I am Dr. George Zachariah from Medical College, Trivandrum. I'll be talking to you on principles of planning in spinal cord injury. Before I begin, let me please forgive me if I'm having a small laryngitis, so I may be coughing in between. So I would first like to thank Mrinal Joshi and Venu for the opportunity, and my patients and my residents and my teachers who are sitting here. Thanks a lot. Yeah, in spinal cord injury, when you're planning, it's the different syndromes. You will have tetraplegia, paraplegia, central cord, cauda equina, etc. And each of these is different. So the planning has also to be taken, the syndromes have also to be taken into consideration. When you are planning, you have to plan in the terms of International Classification of Function. That is, you all know this, that is impairment, activity, and participation. Not to forget the evaluation in the personal social aspects also. Rehabilitation, as you know, is the combined and the coordinated efforts to restore a person to the with disability to the fullest physical, mental, and social and vocational aspects to as far extent as it is possible. The approach to rehabilitation should be inclusive, should take the patient into consideration, discuss it with him. Participative, that is, he should also be part of the discussion. Non-discriminatory, community-based means family-based and community should, if you can involve, that is very good. Preventive, sectoral, and phasic. The phasic part of spinal cord injury rehabilitation is phase 1 is evaluation, then you treat your complications. Phase 3 is enhancement, that you give exercises to strengthen the muscles. Phase 4 is task reacquisition, that is teaching the person how to transfer, how to use the wheelchair, how to do SICC, etc. And then environmental modifications like ramp. The success of an interdisciplinary rehabilitation team depends on the alliance to a mission statement, specified delineated roles of each team member, the balance of participation, that is, when one person is not there, the other person has to just help, and there is a overlap in some of the activities that we do. There is an agreement and then a clear and effective communication. You should have a scientific approach and clearly defined and measurable goals and working knowledge of the group process and the expedient procedures for coming to consensus. There will be a lot of differences of opinion both between your team members and with the patient and with the caregiver. So your job will be sometimes firefighting to get everything together so that the process of rehabilitation moves on. When you set the goals must be specific, it must be measurable, it must be attainable, it must be realistic and time limited. So that's a SMART, S-M-A-R-T. So in time limit, it's actually a little bit variable. Some you would have decided and your goal you would have achieved the goal, but some it may not be. But even then you have to put a timeline so that the planning process so the rehabilitation is good. You have short-term goals which you do in a weekly, monthly basis, and the long-term goals monthly, quarterly to yearly, and it's based on the outcomes in spinal cord injury. Short-term goals actually help you recover safely and comfortably, and it must be specific and measurable. An example is strengthening upper limbs for a person with paraplegia. Let's say take 10 RM, has to be 10 RM is 10 repetition maximum. For the biceps have to go from maybe from 5 kg to 7 kg in a matter of 2 weeks. So that's how you then plan your exercises. And gait training in a person with paraplegia using KFOs and walker. The 6-minute walk test, you want to improve it from 20 meters to 40 meters in 2 weeks time. So you have to be specific and it has to be measurable. The long-term goal may be to make a person with a T12 paraplegia who can sit in a wheelchair to have independent transfers from bed to wheelchair and wheelchair to toilet in about 3 months of time. So then you have to tell your physiotherapist to strengthen the upper limbs. After that, you have to tell your occupational therapist to teach the transfer techniques, and also the caregiver and the rehab nurse to motivate the person to continue doing it. So the performance areas in spinal cord injury rehab is self-care, work and leisure. And the specific areas that you will be planning will be the bladder and bowel continence, prevention or treatment of complications. In mobility, it will be ambulation and transfer. You have to address ADLs, instrumental activities of daily living, work and leisure also. So activities of daily living is very important for this, for spinal cord injury. It's not just the exercises alone. The activities that each person must do on a daily basis for self-care, that is eating, dressing, bathing, grooming, transfers, etc. And goals in spinal cord injury are usually measured in, Barthel Index, FIM, Spinal Cord Independence Measure, WISCI, that is walking index for spinal cord injury, ambulatory grading, 6-minute walk test, and definitely your MRC, ROM, PVR, and voiding volumes in SICC, etc. These measures are necessary because it's a science of measurement in clinical occurrence. In spinal cord injury, the usual ones are FIM, SCIM, and it should be unambiguous, repeatable, and quantitative. It should be unambiguous, repeatable, and quantitative. So FIM, as you know, deals in self-care, bowel transfers, locomotion, communication, social cognition. That's a FIM instrument. Spinal cord injury measure deals in self-care, respiration and sphincter, mobility, and the total score is around 100. That's a SCIM instrument. We should actually try to move into SCIM. We've been trying, but habits actually have to change. It's we've been attempting for the last few months, and still it's not coming through. But SCIM, the study says that SCIM is more sensitive than FIM, and it's more reliable in the SCI population. When you're taking up ambulation, the objective evaluation of walking in spinal cord injury can be done by the walking index. For spinal cord injury, it's very simple and easy, but it's elaborative. That's you have 0 when the patient is unable to stand, and 20 when the patient can ambulate with no device, no braces. And you can see at the end it is a 10 meters. 10 meters is there in every level, and the patient should be able to cover 10 meters, whether it's in the parallel bar, whether it's in the walker, or whether he's using crutches. This is a simple ambulatory grading that we commonly use in spinal cord injury. Grade 1 is community ambulation, grade 2 is household ambulation, grade 3 is physiologic ambulation, or let's say the patient walks in the room. Then wheelchair independent, wheelchair sitter, and the patient. The grade 6 is the patient is on the bed. The outcome of rehab in spinal cord injury is dependent on impairments, the complications, the resources, the team, the family, the motivation that the patient has, the environment, but most important, the individual, his outlook of the person before the injury. Suppose he was a lazy person, then we may find it difficult to get him to do the exercises, but you still have to motivate to make him a little bit better. Or if he was a very outgoing person, we should motivate him to go out and give him a hope, so that then he will start doing the exercises and he will become better, and he will become better rehabilitated. So the functional recovery, prognostication, pre-existing medical conditions, concomitant injuries, secondary complications, cognitive impairments, age, all these affect the prognostication. So you must, before you start writing down the plan, you cannot have a quadriplegia walking. So you must know the outcomes possible for each level of spinal cord injury. The Paralyzed Veterans of America had published it, and they reflect the level of independence that can be expected of an individual with motor complete spinal cord injury under optimal conditions. That's the important thing. You should have undergone a good gone to a good rehab setup at 1 year after injury. So this will be our usual targets. So in respiration, a C3, C1, C4 all will be on ventilator. A C6 will be able to breathe but with low capacity. And at below T10, we will have intact respiration. In bowel and bladder, T1, thoracic levels will become usually independent, whereas the others will require assist. So this is what you should know. C7 or C8, some assist to independence will be there, but thoracics will be independent in bed mobility. And it goes down. In bed and wheelchair transfers also, C7 to 8 comes with certain amount of independence with sliding boards if they are well trained. But the thoracics can become independent. And this is how, you should know this before you start your plan. So pressure relief also C6 can be independent with equipment and adapted devices. Wheelchair propulsion, you can know that powered wheelchair C5 can also do with joysticks, whereas C4 and will need a sip and puff wheelchairs. And definitely thoracics can do manual wheelchair, can be independent of manual wheelchair propulsion. Standing, C6 comes to standing frame, C7 standing frame. Thoracics can become therapeutically independent, but below T10 L1, if trained well, can become independent in functional walking. ADL also, C6 will become independent in eating, and the thoracics can become independent in feeding, dressing, grooming, and bathing. Transportation also, when it comes to driving, thoracics, if everything is brought to the hand controls, the thoracic spinal cord injury, people with thoracic injury can become independent. Homemaking and caregiver assistance is also categorized to the thoracics will require far less caregiving than the higher cervicals. But so this is what to improve on the available muscles and skills. You do not get, if it's a total cut, then you are not going to get recovery, and you have to train the available muscles and skills to improve on their independence. So you have to again go through the phases and start planning. And you start enumerating the impairments, activity, and participation. You can build out a chart. You can write the medical issues, complications, impairment, activity, participation. And then now, after you have enumerated the impairment, activity, and participation, you can again write it down in one column, and on the other side, to each of the impairment, you must write out the intervention. So, which is spasticity, if you decided positioning, you can give baclofen, injection, orthosis, etc. And you decide which team member has to do this particular activity. That is the rehab team, nursing, physiatrist, orthotist, etc. In contracture, again stretching, serial casting, ankle foot orthosis, the physio, the physiatrist, the orthotist, and the patient, etc. So this is how you have to do your rehabilitation planning. And the planning should be followed by an informed instruction to each member after the teammate. So we'll take an example of a patient, a 43-year-old male who was working abroad as a driver and a delivery agent, developed burning type of pain over the right lower limb 3 months back. This is a fictitious case. There's a history of taking heavy weight about 6 months back. The pain was continuous and was radiating from the right buttocks right down to the right foot. The pain progressed to weakness of both feet later on, which presented a slipping of chapels, and he also complained of difficulty in urination in the form of urinary retention. The MRI revealed a massive L4, L5 disc extrusion, which impinged on the spinal canal and bilateral existing rods. So he underwent a laminotomy at L4, L5. And post-surgery, he was given a lumbosacral orthosis. The pain and the weakness subsided, but he had difficulty in walking. There was also dribbling of urine. And the patient was on Foley's catheter for that. On admission at the PMR department, the patient was ambulant independently with instability at the ankle joint with urinary incontinence, for which Foley's was placed. And he was also using the lumbosacral brace. So on examination, moderately built and nourished, the general examination was unremarkable, and he had a healed linear surgical scar. The motor system, upper limbs were all grade 5. Interestingly, at the hip, you can see that the hip extensors are weak. That is 3/5, and he was using the hamstrings to elevate. That is when the patient is lying prone, he can do a prone SLR, but when the knee is flexed, he is unable to extend the hip. So the glutea has become weak, and at the knee also, it was a medial hamstrings that was giving him the power and flexion, and at the ankle, dorsiflexion was there, but the plantar flexion was affected. The soleus was not working, but he was able to manage plantar flexion in the lying down position, in the prone position, using peroneus longus and brevis. He had sensations intact up to L3 and impaired below it. His perianal sensations were present. Anal tone was reduced, and he did not have any voluntary anal contraction. The ankle jerk was also mute. So the investigations revealed the disc disease. He had elevated cholesterol levels. Biochemistry was normal. Cystometrogram, actually infusion was stopped at 350 ml because of patient discomfort. There was no abnormal shoot up. Ultrasound abdomen was unremarkable. We did a balance because he was able to stand. The sway trace length also showed 430 millimeters. And the diagnosis was non-traumatic spinal cord injury, flaccid type, L3 level, ACID, neurogenic bladder, dyslipidemia. So we enumerate the impairments, that is weakness of the hip extensors and lateral hamstrings and soleus, sensory impairment below L3, the activity limit and the loss of bladder control. Activity limit is difficulty in climbing stairs, difficulty in single limb stance, and difficulty in squatting. Participation restrictions were he was not able to go for a job as a driver, and restriction in avocational activities like cricket, because he used to play previously cricket. So he is not able to go to that during the weekends. He is not able to go for playing cricket. We must enumerate again separately the impairments and the medical issues and the complications. That is, weakness of the glutea and the lateral hamstrings have to be addressed, and the soleus have to be addressed. Urinary tract infection, we had a flaccid bladder wall. In the participation, you should not only write what is not possible, you can also write what is good. Or in the activity also, the patient is able to dress upper body, and you can, in the participation, you can say good family relationship, but because of the bladder, he is unable to now go for reduced social interactions. Now you again do the matrix, chart it out, impairment on one side. So weak hip extensors, you can give strengthening exercises. Maybe you can try out electrical stimulation for the glutea. And who will be doing it? The caregiver, the physiotherapist, and the patient. In ankle weakness, again, strengthening exercises can be given. In ankle weakness, you can also address it by either an AFO or an ankle boot. The orthotist may have to make it. If it's an ankle boot, you can ask him to buy it from the shop and then put MCR insoles so that he can walk slightly better. So this is how you should. In a bladder, you have decided that bladder diary and self-intermittent catheterization has to be done. Then the physiatrist, the rehab nurse, the caregiver, and the patient has to be oriented towards training the patient on SICC. So this is how you have to plan out your rehabilitation interventions. And the home, you can give railing along the steps and the bathroom. And the team members involved should be physiatrist, rehab engineer, patient, and the patient. To discuss with the patient before these interventions are done at home. So if a railing is put on the steps, then he will be able to climb and go out to shop. So in participation, you must counsel on trying to do an office job for now, and later when lower limbs are better, maybe he can do a driving. You have to reevaluate again and suggest a car with modifications for a lower limb control. And you, even if he is able to do his lower limb pedals well, maybe you can make the ankle more rigid using an AFO, and you can try it out, but always make sure that he is a safe driver. Because he is on self-intermittent catheterization, he still can continue work, but he has to identify a restroom near the workplace for use. So, participation need not start only after your rehabilitation. You can start asking him to start reading the newspaper at the hospital itself, and the participation can continue. When you are setting your goal, you must identify the impairment, decide the intervention after the discussion, pick up the team members, set a probable time limit, and use a monitoring scale to identify how you can know its progress. And you must review regularly, and remember, you have to modify it. So, in CMC, when I was also working there, we had a initial detailed assessment on admission, then we had a midterm assessment to modify, and a pre-discharge evaluation for discharge planning. So, while planning spinal cord injury rehab, remember we usually tend to concentrate only on the muscles and the bladder. We must still address feeding in quadriplegics, dressing, grooming in quadriplegics again. Bathing will be different for each of the levels of spinal cord injury. Toileting, sphincter management, transfers, and ambulation. We usually progress from the tilt table to the standing frame, to the parallel bar, to the walker, and to the crutches. So, transportation, things have to be brought to the hand, and you must also address outdoor. You should take them outdoor. At our department, we have a tree outside, and they all go out in the evening on the wheelchair and sit. So, that actually improves their interest for participation. Sports, CMC is they're developing a basketball team, and what is your activity? That is ICF. If we put ICF on us, what should we do as a physiatrist? We should evaluate well. We should identify the muscles to be enhanced and improve the balance, investigate to find the bladder dysfunction, prescribe the required orthosis, instruct and discuss about the activities of daily living and ambulation, teach about maintaining a bladder diary and self-intermittent catheterization, and encourage the person and the family to achieve a better function. And what is your participation? You have to be like a grandmother, look for the impairments and things missing, and guide your rehabilitation team. You have to be a surgeon, you may have to do slough cutting, flaps, and grafting. As an engineer, you have to know a little bit of biomechanics, the ground reaction forces, and then decide on the orthosis that the person needs. Like a football captain, you have to interact and pass the ball to the other team members. And like a friend, you have to help the patient to make a wise decision. And as a doctor, you have to be scientific, you have to evaluate and treat with interventions. And thank you for patient listening. The lower two pictures actually show was Onam celebration. One is the flower arrangement is, one is inside the hospital and the other is outside the hospital. So, it doesn't mean that participation should only be outside. You can start participation from inside and progress to outside. This picture, I am not the expert at it. This is Paralympics. So, maybe the young physiatrists who are going to develop the departments should reach, so that we can give good training for the spinal cord injury in Paralympics also. Thank you.